Hi everybody, it's Emily. My presentation is on tracheal foreign bodies and relevant anatomy. So in this presentation, I'm going to walk through some of the structures we need to know for the thorax, as well as 2 case studies on tracheal foreign bodies. So the first thing to do is go through this PA radiograph. You can pause the video here and make sure you appreciate all the structures. So in the PA radiographs, they are PA instead of AP because AP can artificially enlarge the structures. I personally like to review bones first and then move on to softer tissue structures, but no matter how you do it, it is important to be systematic. Up here you can see the clavicles, their heads right in the middle, really lined up with the spinous processes. You can see the T1 spinous process right here. So this patient was lined up with the sensor. You can appreciate the scapulae with their medial borders, and you can follow the ribs across. Here's rib 1, it joins with the manubrium about the T3 level. Here's rib 2, you can follow it across. It joins with the sternum about the T4-5 level, which is your sternal angle, which is important. You have the beginning and end of your ascending aorta, your aortic arch, as well as the carina with your trachea. Further down, you do have your xiphosternal joint at T9. It is a little difficult to appreciate here, but with your ribs, remember 1 through 7 are true, 8 through 10 are false, and then 11 and 12 are your floating ribs. You can kind of see them down here. You can also use your mediastinal contour, the outline of your central structures, to determine some of the anatomy. On the right side, the outline shows the superior vena cava, the right atrium that's lighter due to having a little bit less muscle mass, and the inferior vena cava coming up to meet it. On the left side, there's the aortic knob, the AP window for the pulmonary trunk and left pulmonary artery, and part of the left ventricle. Remember, in these views, most of the anterior of the heart is the right ventricle, so you'd only have a little bit of the left ventricle right here. Moving on to the lungs, I like to go around the ribs, look at the costodiaphragmatic recess, make sure there's no blunting, and look for any other abnormalities. You can use the silhouette sign to determine the location of structures, but it's also useful in IDing pathological change. So the ascending aorta right up here is going to be your right upper lobe of your lung. Your right heart border is going to be your right middle lobe. Your right diaphragm is going to be your right lower lobe with your liver right underneath. Your aortic knob on your left side is going to be your left upper lobe. Your left heart border is going to be your lingula and cardiac notch, as well as your descending aorta and diaphragm on the left side is going to be your left lower lobe. Remember with the diaphragms that if you have free air in the abdomen or a pneumoperitoneum, you may see a slight outline in the subphrenic space. In this image, you can also see a gas bubble in the stomach as well as part of the transverse colon. You can see the plicae semicircularis forming the haustra, as well as the splenic flexure going down into the descending colon. Also, to drive home the point that it is important to go through systematically and appreciate all the structures. I'm sure all of you found this. If you paused the video and went through all the structures, you found this. But it is really important to go through systematically, make sure you don't miss anything, and a few of you might have missed this guy right down here. To also highlight the relationship of the aortic knob and the AP window with the pulmonary artery, I just overlaid this picture right here. It just makes it a little easier to appreciate all the structures. This one isn't quite accurate. This is more right ventricle in the front, so there would be less left ventricle over here. It would be just a little bit over here. You can see the aortic arch isn't quite up to the aortic knob, but you get the idea. So case 1 is an 8-year-old male that was referred to an outpatient ENT for sudden onset of cough and dyspnea with a chief complaint of aspiration of a foreign body. I wanted to point out that the majority of foreign bodies are common in small children or incapacitated individuals. The most common signs are sudden onset of cough, shortness of breath, and wheezing. So here is the picture if you wanted to pause the video here and walk through the structures and try and determine the foreign body. So this patient, he had a PHX x-ray taken. His history was actually accidental inhalation of a tooth during a dental extraction. So you can see right here, pretty easy to see. But it is important to note that up to 30% of tracheal foreign bodies, they won't appear on an x-ray. So since he had a history of a tooth that was inhaled, obviously bone would be radio-opaque and pretty easy to see. So x-ray was their go-to. But you can see the trachea coming down, bifurcating into the right and left main stem bronchi, all the ribs across, but again, that tooth is pretty easy to see. It is interesting that it went down the left instead of the right. You can kind of see how much more vertical the right main stem bronchi is compared to the left. The findings were reduced air entry to the left lung upon auscultation. Everything else was within normal limits. Bronchodilators were started. The tooth was removed under general anesthesia. The patient was given antibiotics and was released 48 hours later. So case number 2 is a 50-year-old male with a chief complaint of persistent cough for 3 months. I will bring up the picture. You can pause the video and go through all the structures and try and figure out what the foreign body is. So this patient actually, he had persistent cough for 3 months after eating a chicken bone and swallowing it. It can be difficult to determine foreign body inhalation when the patient doesn't realize that they've actually swallowed something. So my assumption is they did a CT, probably due to the fact that the patient didn't realize he actually inhaled a foreign object, and also to rule out any lung or thorax pathology. So you can see with this lung window, it's very easy to appreciate the lungs, but you do lose some resolution out here. You can appreciate the aortic arch and descending aorta, looping over the left pulmonary artery and the left main stem bronchus with that foreign body right there, that little chicken bone. Again, calcium would show up, but as you can see right here, it is taking up a good portion of the left main stem bronchus. This is an axial lung window, the same CT. You can appreciate the ascending and descending aorta, main pulmonary artery bifurcating into the right and left. You can see they also decrease in size moving laterally. I'm not really sure what this hyperdensity is. My guess is it's a calcification or a medical implant, because on CT, remember, chronic hemorrhage, edema, and air hypodense are dark with those negative to low Hounsfield units. An acute hemorrhage, contrast, and calcifications in bone, like right here. You can see your ribs are hyperdense or bright with the high Hounsfield units, up to positive 3,000 for dense bone. Just posterior, you can see we're past the bifurcation. We're about this level right here. You can see the foreign body in the left main stem bronchus as well as the right. The descending aorta, it's a little hard to appreciate, but you have your azygous vein or azygous vein, as well as your thoracic duct would be right here. Given these structures are present, I would say this is about the T5 level or the main pulmonary artery level. And this last picture I just wanted to show you, comparing the coronal CT. One of the good things with CT is you can make these 3D models of your images. Sometimes it's a little easier to see. You can actually see the chicken bone right in here, but it is also easier to appreciate the normal lung anatomy, as well as like the trachea coming down at the carina bifurcating into the right and left main stem bronchi, how the right main stem bronchus is much more vertical, the normal anatomy of the lungs, the lingula, and cardiac notch. And here are those cases if you wanted to go check them out on Radiopedia.